So let's run through OCD. Starting off with diagnosing it, obviously you need to understand what an obsession is. An obsession is a recurring or intrusive, persistent thought. It can also be an image or an urge that interferes with normal behavior. And then as a result of those obsessions, people with OCD perform compulsions. Generally, the compulsion is a behavior or an action. Remember that it can be a physical or it can be a mental action. But the point is, it's repeated, it's purposeful. They feel that they must perform it in order to alleviate the anxiety, either according to their own strict rules or in a certain way. It's important that it's not connected in a realistic way to the feared event, or it's clearly excessive. It goes beyond what would be relevant at all. So washing your hands, if you're worried about contamination, obviously washing your hands is connected in a realistic way to the feared event of getting sick, but washing your hands repeatedly after not touching anything else is clearly excessive. Like it says there, it can also be mental, and it usually offers relief temporarily from the anxiety or distress that's caused by the obsession. So you have the thought, you have the emotions that the thought produces, and then you have the action the person does in order to alleviate that temporarily. Now, in order to be diagnosed with OCD, it needs to be time consuming. You need to spend more than 1 hour per day on either the obsessions or the compulsions or both. And obviously, it either needs to cause that significant impairment to the areas of psychosocial functioning, like relationships, occupation, social interactions, education, or it needs to cause significant distress. So you may be able to continue in those areas of functioning, but it's causing you significant distress. The case study that you can be aware of is for diagnosing would be Judith Rappaport and Charles. I won't read this whole thing to you. Again, obviously, I'll let you read it. Rappaport didn't treat Charles. This was more of a case study of the progression of his disorder. This visual I just found it helpful to remind you of some of the most common obsessions, and then the kind of dimensions that they fall into, and then the related compulsions. Just to give you the contrast between the DSM-5, which we use here in the United States, the Diagnostic and Statistical Manual, and then the International Classification of Disorders, which is used internationally. This is what the British use. So this is the ones that you should be familiar with. But I put them side by side just so you could kind of see. There's 2 measures of OCD that you'll want to be familiar with for the ACE exam. You've got the Maudsley Obsessive-Compulsive Inventory and then the Yale-Brown Obsessive-Compulsive Scale. The Y-box is the the main measurement that they used in the required study for this one, level. So just remember that. We'll take a look at it real quickly. Remember, the first 5 items deal with the obsessions. This is a 5-point scale from 0 to 4, so the max score is 40. And then the last 5 questions deal with compulsive behaviors. Generally, there's a self-report version of this that the person can fill out, but generally it's done via a clinical interview. The clinician will ask the questions, and just because some of this you might not understand, so the clinician will ask those follow-ups and ask those questions, and then they'll assess on that scale. There's also a symptom checklist that's part of the Y-box. Now, if we get into our explanations, there is, of course, a genetic explanation. Manzani, just an example, did a twin study and found that the concordance rate for OCD was higher among monozygotic twins than it was among dizygotic twins. Of course, monozygotic twins share 100% of their genes, whereas dizygotic twins only share 50% of their genes. So we would expect there to be, remember, a concordance rate is when both of the twins have it. So we would expect it to be higher among those who share 100% of the genes. But as always, that being said, if it's strictly genetic, then 100% of identical twins would both have it. So this both suggests an obvious genetic element, but also provides evidence for some kind of environmental factors as well. Like most disorders, it is polygenic. It includes multiple genes. They haven't narrowed it down to just one. Ozaki found evidence for the SERT gene, which codes for serotonin, which makes sense because we know that serotonin has a role here. Matheisen did a GWAS, a genome-wide association study. Remember, that's just where you get a number of people rigorously diagnosed, because it's important. Because think about it, if you are, we talked about with bipolar, when we talked about the Aruch study, which was genetic, you have to be careful, because one of the reasons that they had a hard time for a long time doing any of this analysis in schizophrenia is because they were not super rigorous about who they included. And they had this problem with depression as well. They didn't only use people with bipolar type 1, they would use like also people with bipolar type 2. But if you are rigorous about your sample that you choose, which Matheisen was, 1,406 patients with OCD, and then compare that to the general population, a GWAS looks at the entire genome. So instead of being like, all right, we think it might be some of these candidate genes and testing just those, a GWAS looks at every SNP, a single nucleotide polymorphism, a single nucleotide polymorphism. Remember, polymorphism is kind of a mutation. So what a GWAS does is compare those two and find every different SNP. So this can give you a lot of candidate genes. Based on this, it suggested a role for PTPRD and SLITR-K3. SLITR-K3 in particular, Shmelkov then did an example study, and remember, Shmelkov created a population of rats and just deleted the SLITR-K gene altogether, SLITR-K3 gene altogether. Those were called the knockout mice. And then those knockout mice were compared to wild type mice who hadn't had the gene deleted. And those rats, those knockout gene rats, showed increased grooming behaviors compared to the wild type rats. You can see here the knockout mice showed about 13 seconds per minute of grooming, and the wild type only showed 3. They groomed so much that they showed these facial lesions. So that obviously doesn't prove to us that these mice like got OCD, because presumably the mice weren't having obsessions, or we have no way of knowing it, but they were kind of showing this compulsive behavior. Interestingly, these behaviors were successfully treated or stopped when the mice were treated with SSRIs, which are the main biochemical treatment for OCD in humans. Biochemically, we know that OCD is associated with serotonin dysfunction or dysregulation. We know that this affects the CSTC pathway in people with OCD. This is the basal ganglia, this kind of odd little structure here, and then here you have the thalamus. The CSTC pathway starts with the C is for the cortex. The orbitofrontal cortex what it does is take in and it sends alarm messages. So one thing we see in people with OCD is that the orbitofrontal cortex is overactive. It's hyperactive. It's sending messages constantly that something is wrong. And it's the job of the caudate nucleus, which is part of the striatum. It's the job of the caudate nucleus here to be a filter, to be a gatekeeper, to say, okay, that's a serious one, we should send that on, or that's not as serious, we don't need to react as strongly to it. It's supposed to filter out those intrusive thoughts, stop things when they're no longer useful, make a lot of like evaluative decisions. That's the filter or the gatekeeper. But one thing we know with OCD is that the caudate nucleus doesn't do that successfully. It lets everything through. It doesn't down-regulate those repetitive signals that the orbitofrontal cortex is sending. We remember, I'm sure, that serotonin has an inhibitory role here. That's the down-regulating. Serotonin is supposed to slow down that go, that excitatory go process that's happening here. But there is a dysregulation in the serotonin, and it's not doing that. But the caudate nucleus doesn't filter those out. They send those messages on to the thalamus, and then the thalamus amplifies it. It does not shut it down because it has been sent on from the caudate nucleus. it sends it back to the cortex and we get this loop. Another thing we know is that people with OCD often show excess dopamine in these areas in particular. Dopamine is the gas pedal here in this circuit. So too much dopamine pushing this circuitry along, because that's what this is, brain circuitry. Too much dopamine pushing it along, not enough serotonin that is acting, having an inhibitory effect. Which brings us to our psychological explanations of OCD. We'll start with the cognitive explanation. As always, a cognitive explanation for disorder is some kind of faulty reasoning. In this case, we're going to talk about thinking errors. The cognitive really focuses on the obsessions because the compulsions are the outcome of these flaws in reasoning. Remember that when OCD is assessed, one of the things we see in the ICD is that some people with OCD have higher insight level. So through conversation, they can see that many of their thoughts are irrational, their obsessions are irrational. It doesn't mean they don't perform the compulsive behavior, but the insight level has to do with whether they're able to see that. People with poor insight can't see even the flaws in the reasoning. But we know that these thinking errors, these obsessions get worse when life is stressful. So obviously your contamination fear is causing stress, but your life generally. So if you're having difficulties at work or something else is happening and you're dealing with more stress, the OCD, the cognitive aspect is going to worsen. And of course, because the compulsions are a reaction to the obsessions, they're going to worsen as well. A couple of thinking errors that are specifically associated with OCD, you can see them there. They're kind of related. Remember that one of those is called thought-action fusion. People with OCD think that thinking about something makes it more likely to happen, that their thoughts and actions are fused. So people who have, for example, harm OCD and worry that they are going to hurt someone that they love, they can't obviously control that thought that's popping up in their orbitofrontal cortex, but for them, they're just the act of thinking it makes it more likely to happen. So that really increases, of course, the anxiety that they feel. Also, sometimes with the forbidden or taboo obsessions, this other part will come into play, that thinking something is just as bad as doing it. And this part really gives rise not only to anxiety, but also to guilt. You could obviously have this part come into play with harm anxiety as well, because if you're worried constantly about hurting the people you love, if you're a mother and you're constantly worried about intentionally causing harm to your child, you're thinking it, so you think it's more likely to happen, but also just the fact that you're thinking it feels just as bad as doing it. So you're dealing with that anxiety and especially that guilt. One thing I didn't talk about with Freud, but I want you to memorize the toilet training thing because that's what ACE has. But Freud really said that all of these compulsions were a way of dealing with guilt. So if it wasn't about toilet training, he often believed that there was some unresolved conflict, some guilt, no doubt about some weirdly inappropriate thing that your id wanted. And these compulsions develop as a way of resolving that guilt. So that kind of links a little bit to that. But also associated with OCD is a feeling of inflated responsibility. Now, obviously, if you drive drunk, you may very well cause harm to other people. So then you would be responsible. But this sense of way out of proportion, this belief that you have pivotal power to either cause or prevent these negative outcomes. So obviously, if you think that you failed to perform your compulsion, if you don't keep all of the things arranged in order, that's going to cause this bad thing to happen to someone you love, or that you, by doing that, can prevent it from happening. Obviously, if this is a realistic concern, then it's not OCD. But typically, this is something that is outside of your power, or you are giving yourself way, way more responsibility than you really have. So both of those are your kind of specific thinking errors. Then we'll get into our behavioral. Remember that the behavioral explanation for the impulse control disorders has to do with the idea that you learn. That you learn through a reward. That's you get some kind of positive reinforcement. With gambling, it's very tangible. You have a big win and you learn that the outcome of gambling is that win. You also have that partial positive reinforcement. So because you don't get it every single time, it actually becomes more addictive. Remember, we memorized that the striatum, as the brain's reward center, is part of that. this seems like a great time to point out, remember the CSTC loop. There's a reason that the striatum is involved, because the striatum is part of habit forming. So as you see this overactive activity in the CSTC circuitry or pathway, that's linked very closely to here with the role that the striatum plays in learning and in the formation of habits. Because that's what an obsession is a habit that you learn. That's what the compulsion is the habit that you've learned as a way to deal with the obsession. We would call this maladaptive learning. You adapt by performing these compulsions to these obsessions, but you do that in such a way that it's harmful to you. It's irrational and harmful to you. That's why it's maladaptive learning. In this case, we're dealing with operant conditioning. So was ICDs, obviously. Positive reinforcement is operant conditioning. Here we're dealing mostly with negative reinforcement, but let's contrast that, of course, with phobias. Phobias are formed by that classical conditioning, that unintentional association of the two things, or intentional if you're John Watson. So in this case, the whole idea is the obsessive compulsive behaviors, really the compulsive behaviors are learned. Hand washing, for example, is reinforced because it takes away something that produces anxiety. It takes away that, this is a little imprecise. It doesn't take away the thoughts. It takes away the anxiety produced by the thoughts very temporarily. So it reinforces that behavior. The difference between a negative reinforcer and a positive reinforcer: a negative reinforcer is something that is taken away. A positive reinforcer is something that's put on. So if they were to mention that the person feels rewarded or feels something added on, like the reward of that clean hands, that would be positive reinforcement. I would be happy if you explained it as negative. Then, of course, we have our psychodynamic explanation. For Freud, a lot of the time this happened because of some trauma or conflict during the anal stage. Remember, of course, that we all progress through these stages in Freud's mind. It doesn't happen so not everyone, of course, would have some conflict during toilet training. So not everyone would develop it. But he believes that this is all a result of a subconscious conflict that occurs during the anal stage, which is when most children start to toilet train. There's tension no matter what. I haven't heard a lot of stories where parents were like, and then toilet training or potty training was perfect and easy. So there's tension. Parents are wanting to control how and when the child defecates or urinates, and that's something they haven't done before that. Before, the kid was just free to pee and poop whenever in a diaper. So some children may become anally expulsive. They may soil themselves or poop wherever they like, which obviously can lead to upset and arguments. But some children will hold it in. They're afraid of overly harsh responses from parents, so they become what we call anally retentive. Freud said that OCD was associated with those anal retentive personalities. He said that people that developed that anal retentive personality, some of the personality traits related to that were orderliness, stubbornness, perfectionism, needing control. And for him, those all were linked to neurosis. We didn't have the word OCD in Freud's time, but he referred to those compulsive behaviors and those thoughts outside of your control as neurotic. He also linked a fear of contamination to a desire for control. So he was like, okay, then you're doing all that compulsive hand washing as a way to satisfy that. No empirical evidence, no little Hans here to be like, little Hans is questionable as evidence, but none really here. This was just like his theory. When we get into treatment, obviously the most common biological treatment or biochemical treatment is SSRIs. We've talked a lot about these, so I'm not going to say a whole bunch about them. Remember that the transporter, that is where the SSRI goes and blocks. The job of the transporter is kind of a vacuum to clean up the synapse, because the message is trying to get from this presynaptic neuron to this postsynaptic neuron. We want it to make its way here, but we don't want it to just float around here in the synapse forever. So the transporter's job is to vacuum up the excess. So the SSRI, by blocking that transporter, it prevents the transporter from vacuuming it up and makes sure that more of these will get to the receptor and actually carry that message that alleviates that anxiety. The psychological treatment is CBT, and specifically it is something called ERP. So ERP is exposure and response prevention. The basic way it works is you expose your participant or your patient to a stimuli that would otherwise provoke that obsession or distress, and then you don't let them form the compulsive behavior because they have learned they've learned a maladaptive behavior pattern. Whenever the obsession arises, they do the compulsive behavior and they feel better for a very, very short time. But that's not what we want. I went and pulled these actual handouts from a therapist website. So it will often start with some kind of thought recording or thought log where the patient will pay attention to those triggers that they recognize. And after some psychoeducation, the therapist and the patient the therapist will lead the patient in a case formulation. They want to really understand the case and the patient's triggers. So using what they came up with before, if I'm exposed to this trigger and I do not neutralize it by doing this compulsion, this is the catastrophe that will occur. This is the exact thing that I believe will occur. This also leads to me avoiding these other situations. So once the therapist and the patient have gone through that and understood that, they will create an exposure hierarchy. Obviously, they're going to order them from the least level of challenge, the least threatening kind of trigger or stimulus, to the most. Obviously, you could see this inverted. You could be starting at the bottom if these were the lowest. It doesn't matter. Just know that obviously you're going to tackle them in increasing levels of difficulty. Then you're going to create a very specific response prevention plan. So when my fear obsession tells me to do this compulsive behavior, I will do this instead. You can see that you're going to have the patient plan to do certain exposures. That's going to be they're going to do it there with you in the office most likely, but then they'll also have homework to complete a number of these each day to really cement that learning. Because remember, we've had maladaptive learning. Now we need to do some learning that is rational and is going to help them. So you can see this handout mentions the planned exposure time, but also what happens when I have the triggers outside of my planned exposure time. So I planned that I will touch an unsanitized doorknob and not wash my hands 10 times. But I know that I may also encounter that. So the therapist would want the patient to come up with come up with a plan ahead of time for how to deal with that. Then you're going to record those exposures. This is just an example of a tracking log. And you're going to record those exposures for your therapist. You're going to write down the date and time, how long that the exercise lasted, what was your initial SUDS rating, what did it peak at, because it probably went up, and then what did it come down to, and take notes on it. And then by doing this, of course, it requires that homework practice, but by doing this, you will learn that the obsession is wrong, that you won't die if you don't perform that compulsive behavior. The example study is one from a woman called Heather Lemkool. Her case study, I linked it somewhere towards the end, so you can read it if you want to, was about a 12-year-old named Jason. And Jason was kind of unique because he had OCD, but he also had a diagnosis of ASD. He had a contamination fear. His behaviors were hand sanitizer, hand washing. He particularly he would spend a lot of time checking the expiration dates on food. He had a hard time touching his textbook, his desk at school. So he spent several hours each day, and it caused him significant anxiety. He was treated by Lemkool in 10 50-minute CBT/ERP sessions over 16 weeks. One thing she says that made Jason's treatment path a little different than the average person. Because of his autism spectrum disorder, she did not spend a lot of time on the cognitive aspect. Jason struggled to articulate what exactly his obsession was. He struggled to identify whether his response to something was normal. So Dr. Lemkool taught him to ask himself, would a friend be worried about this? But she said that instead of starting the exposure and response prevention in week 4, she went ahead and started it in week 2 because the visualization exercises, doing them in vitro instead of in vivo, didn't work for him just because of his cognitive difference. For him, the steps of the ERP, he was obviously taught to identify those feelings of distress instead of really trying to like challenge and do cognitive restructuring in a way that you would with someone who is neurotypical or an adult. He just learned these coping statements. So for him, he just learned to say, I know nothing bad is going to happen. Then, just like always, this systematic desensitization, he was exposed to those threatening stimuli or those triggers in increasing difficulty. He was asked to touch those items because he had contamination OCD. He was asked to touch them repeatedly until he became habituated. That's to the point where your anxiety drops. And then he practiced at home between sessions. The full case study describes how he also like practiced at school. His teachers were very supportive of it as well. For him, his Y-box started in an 18. Remember, 16 is clinical. He started in an 18, and by the end he was at a 3, and his score was still staying low at a 3-month follow-up. So it worked well for Jason. You can read, I'll link that so you can look at it if you want to. It's worth reminding yourself of the differences between biochemical or biological and psychological treatments. It's always a good thing to think about. They love to ask about it. And then, of course, I've got a separate video for the level key study.